Hi everyone, thanks for watching this. My name is Vian Vu. I am the current Division I Sports Physical Therapy Fellow at Wake Forest University. Today I'm going to talk about social determinants of health and population health and the idea of treatment beyond the clinic walls. I do want to disclose that these views are my own. Anything I say is not a reflection of the views of Wake Forest. Today I hope to discuss the social determinants of health and why they matter. I also hope to review how implicit bias affects our patient outcomes and also talk about barriers and solutions to population health. So to start, does anyone recognize this? I'm sure most of you may have seen this if you work at Wake Forest and also many hospital systems, but this appeared on our EMR Epic. In the most recent update in summer 2019, whenever you click on a patient, this is the first thing to pop up on that patient's profile in the lower left-hand corner. And whatever social determinants are, obviously it's becoming important, and even the EMR system decided that's important to keep it as a forefront to show us that there's certain factors that we should be mindful of before we talk to a patient, evaluate them, and give them an intervention. So what are these social determinants of health? They're conditions which people are born in, grow in, live in, work in, and age in that affect their health. As you can see on the picture on the right, these categories are sectioned off to economic stability, built-in environments, education, food, social factors, and the healthcare system. Furthermore, you can see below that there's a list of subcategories of these that you can take a deeper dive into, and we can also look at if we want to improve healthcare outcomes in these areas. But like I said, all these factors, if you look at the orange, can lead to or have relationships to mortality, morbidity, life expectancy, healthcare, expenditures, health status, and functional limitations. What is population health? This is defined as an interdisciplinary, customizable approach that allows health departments to connect practice to policy for change to happen locally. Public health is more of broad and nationwide, and it's something that may unintentionally exclude certain groups because it's so broad. Whereas population health, it's going to affect on what we can do with community groups to affect the community that we grow up in and develop our families in. So we can look at underserved groups a little bit better. We can look at our local data and look at which groups might be good targets of certain interventions and may benefit from certain services. So why are we talking about this? Right here, I have the mission statement of the American Medical Association, the American Physical Therapy Association, and the American Academy of Family Physicians. These are all organizations that we are a part of or that are well known in the healthcare system. And notice that all these organizations talk about public health, society, and communities. So thinking about these words and what it brings up in your head about serving the public as a whole in our communities a lot at once, I'd like to challenge everyone today to think of a question that I'm challenged with every single day that I work up and go to work, or that I wake up and go to work. And that question is, are we making a societal difference by treating one patient at a time in clinic walls, or is there a greater need to impact those beyond clinic walls? And I think that question should be in your heads as we go through this whole presentation. So we only see a limited amount. I know 6 in a day isn't that much. That'd probably make you guys a lot less stressed out. But for this example, are we really doing much? Can we really affect society if we're only seeing this many people a day? Or can we develop programs to treat people outside of the clinic that can perhaps make a bigger impact on our community's health outcomes? This can also be explained as upstream versus downstream care. So I lived in Wisconsin last year, West Wisconsin, a little town called La Crosse. It's right along the Mississippi River. Up north, the Mississippi River really doesn't branch out too much. Yet when you get downstream, it does branch out a lot. So downstream can pose a lot of problems. Let's say there was flooding in certain areas or all at once. We'd have to allocate resources and power to those areas. So we'd have to be a little bit spread thin. We'd have to plan where certain things go. It's a lot trickier to treat these problems. Whereas if we treat it upstream and we can prevent it from even getting down there, all resources are in one area and maybe it might take a little bit more, but you can see that it might save us overall long-term if we just think about preventative care. Does this sound familiar to you guys? Kind of like flatten the curve during this time of COVID-19, right? So similar things that we're talking about, but in this respect, I'm really talking about cardiovascular disease and metabolic disease, because I do think those are highly preventable and can be determined by behavioral changes. So now that you understand this concept, let's break down those areas of social determinants of health so we can better determine how we can fix those areas. And I put this up here because this is what we look like when we're in downstream care. We're just doing everything at once, when I think if we have more help and work together in preventative fashion, we can be less stressed out. So we're going to break down social determinants of health into two different types of factors. The first being socioeconomic factors. First, we're going to talk about wealth. Wealth is our access to certain resources. The last resource you have access to, of course, your health outcomes are going to be more poor. Looking at the graph on the right, you'll see that medical and healthcare costs are the biggest proportion of unpaid debts. Access to insurance can help with that. It can lower costs. If you have insurance and you have lower costs, you're more willing to get healthcare or see a physician, and you're more likely to have better health in that sense. However, I do want to mention that not all insurance is equal. Access to insurance doesn't necessarily mean you're going to get the best care. So there's a little subgroup that you can look at that too. In Dickman's study in 2017, they looked at some studies and found that 76% of orthopedic specialists declined Medicaid insurance for minors diagnosed with fractures. They also found that the average cost of deductible was $1,500, while most people choose a tier of deductibles that cost $3,000. Pretty sure we can all raise our hands if we asked around the room, how many people know people that pay upwards of $5,000 for the deductible? On the other side, wealth is your access to resources. Riches is how much money you have. And talking about riches, 39% of low-income patients don't see their doctor due to low costs. This is alarming because if people don't see healthcare practitioners, not only can they not be treated for things and things can get worse, but also it takes away times we can help them. Whenever we see a patient, we just don't help them with the things they need help on. We always ask them, is there anything else I can help you with? We can provide a screen for anything that might be preventable later down the line. And we can also provide education on just general good, healthy behaviors. If we don't have, or if people don't have access to this kind of care, or at least less likely to seek this care, that can affect their health outcomes as well. You can see in this graph as well, looking at income, that, so this is life expectancy. And the more people in poverty have a lower life expectancy. And this study that looked at this graph was in 2011, and the data is from 1988 to 1998. So I'm willing to bet the life expectancy is far higher than before, but I'm willing to bet that also the trend is the same. So although the actual numbers are different, I think the trend is likely the same. But what about education? So in that 2011 report by the Robert Woods Foundation, they looked at the ethnicity and education level, and they looked at the y-axis, which is the chances of someone living after the age of 25, which is very young. And they subgrouped it into different ethnicities, and they found that the higher education you have, the better chance you had of living past the age of 25. Looking at education again, you can see that it affects, or what you're born in can affect you too. This looked at the mother's education, and the infant mortality rate is higher in those whose mothers had less years of education. So some things you don't even have control at birth, but can be certainly influenced if we take care of the mothers. Occupation can also be a factor. You can also have job-related hazards that may put you at more risk for injury, but also, again, talking about the income of it, how much they pay you. Next up, we talk about geography in the built environment. Geography can play a role. If you have, or if you're living in a rural area, you might drive quite far for healthcare and you may be less likely to seek it. In Wisconsin, I had several patients who would drive 2 hours for physical therapy. And at their eval, I said, we're going to try to make things work where we give you some home exercises. You're going to take care of this. So not only are you less likely to have access to practitioners and facilities that are close to you, but also consider the fact that some people might not have transportation in different age groups that might get there. The other side too is not a lot of specialists are in rural areas. So again, the quality of care is going to affect health outcomes in rural areas as well. The built environment is classified as what your city and town looks like. So if you can, we're going to talk about, as far as built environment goes, walkability. So an area of high walkability has sidewalks, has traffic lights, isn't as dense with cars. And you can see in the top picture, an example of that. An area of low walkability has no sidewalks, no stop signs or less stop signs, no speed bumps, a lot of chances for accidents to happen. So Hines in 2018 talked about the built environment and its direct relationship to cardiovascular disease and also overall death. One thing they found was when they looked at walkability measured by certain index scores that combines all the factors I had just mentioned, they found that with high walkability areas, there was a 2.4 times more likelihood that someone's going to get 30 minutes of exercise. As we all know, exercise is medicine, and that can prevent a lot of metabolic diseases and cardiovascular diseases. Also in their study, they referenced another study that followed residents from moving to a town of low walkability to a single town of high walkability. And in these subgroups, they classified certain people as low exercise group, moderate, and high exercise group. So those who moved from those in a low exercise group that moved to this certain town in Texas with high walkability, they increased their exercise by 176 minutes per week. And this was classified as sufficient levels of physical activity. Even those with already moderate to high exercise, when they moved to a high walkability area, their minutes per week increased by 70 minutes. You can also understand that a safer environment such as walking can affect certain age groups such as older adults and children. They're going to tend to exercise more for safety, or they're going to exercise more with safety features around. These safety features can be speed bumps, roundabouts, community fields, and designated bike lanes. So the safer the environment is, the more willing people are to exercise. They also referenced an 11-year study that looked at obesity. And in that study, they found that low walkability areas, obesity grew, of course. In high walkability areas, things stayed the same as far as obesity rates. In a similar study that looked at cardiovascular and metabolic disease and depression, they found that high walkability areas were associated with decreased depression, decreased metabolic disease, and decreased cardiovascular disease. As far as the high walkability areas, so those were decreased, and low walkability areas had increased rates. Next, we're going to look at factors that refer to social constructs and identity. So culture can certainly play a role. I'm going to leave it up to your guys' thought process on this, but you can understand maybe how culture around food and health might be different in California, might be different in the Midwest, Wisconsin, and might be different in North Carolina. Culture can certainly lead to health disparities. Next is ethnicity, which we're going to go into a deeper dive later, so I'll just list that here. But you guys can already kind of think in your head what you know, what you've learned and experienced, that ethnicity can certainly affect it. Same thing with gender. With gender, I am going to go into a deep dive to see how our implicit bias as practitioners is going to affect the outcomes of our patients based on their gender. But one thing I wanted to note that with gender, as far as females go, is that we all know there's sufficient evidence to show that females unfortunately get paid less than their male counterparts, yet they have to pay for more medical services. So that can lead to poor health because they have to spend more, yet they're making less than males. But as far as like health outcomes and how we might affect their outcomes, we'll go deeper dive into that. And then sexual orientation is going to play a role into your health outcomes too. I'm not going to go into too much of a deep dive of this because that's a separate talk for its own. But in short, they don't have quite the same rights as all of us do, or the gay community does not have the same rights as the heterosexuals do. But let's take a deep dive into ethnicity and gender at this point. So let's ask the question, does ethnicity and gender affect the way we treat? This study in 1999, I know, hear me out, we're just gonna go over an old study. But in 1999, the purpose of the study was look at clinical decisions based on sex and race. What they had was they had 729 physicians sit down and watch some videos. In these videos, there were 8 actors. These 8 actors are pictured on the right. There were 2 groups of each. There were 2 groups of black female and a black male, and then 2 groups of a white female and a white male. What these actors did was they acted out and showed 6 different descriptions. So these descriptions were based on race, sex, age, level of coronary risk, and then based on that, the physicians were supposed to classify them into different 3 different classifications of chest pain, and then they could also order stress tests, vitals, smoking history, and labs. So when you look at this, 8 actors, 6 different descriptions, and 3 classifications of chest pain, there's 144 different scenarios. So once these physicians looked at all these videos and then classified all these scenarios as definite angina, possible angina, or non-anginal pain, they had to characterize them into referral for catheterization or no catheterization. So they were going to determine their intervention and referral based on these factors. Interestingly, in all these videos, every single one of these actors were trained to do the same hand gestures, facial expressions. So really the only thing that was out there for practitioners to have a difference of was their ethnicity and their gender. So all the videos were the same, all presented the same descriptions or a number of descriptions. They were mixed up, randomized, and the physicians categorized them. What they found in their analysis was that females and blacks were significantly less likely to get appropriate catheterization. So the people who developed this study were 4 cardiologists, and they determined that based on these scenarios and what these people described, these people needed catheterization. They were appropriate for catheterization. And you can look here that in the group that was appropriate for catheterization, females were referred less, and the black group was referred less. Maybe that's not enough. In a separate study in 1996, this looked at a black group and a white group, and it looked at surgeries. So for everyone who would benefit from these surgeries, it was shown that the black group were less likely to get these procedures even though they needed it. So there seems to be the way we treat seems to be affected by our implicit bias of ethnicity. Well, you might be thinking right now, 1996 and 1999, times are changing. It's not so much this way anymore. We are aware that racism still exists. Implicit bias is a thing, but surely we don't do this anymore. Well, you might be wrong, because I looked at a recent study in 2018. This was a systematic review that looked at something called implicit association tests. And that's basically a test where when you look at the race, and you can take this test for age and other biases, but they looked at just race. And what this test does, let's say we're looking at a white group and a black group, and what they have is a picture of a black individual and a picture of a white individual. And then a word will appear. Right when you see that word, you have to click one or the other. Based on the speed you click it at and who you click, it's going to give you a bias of what more group you're towards, a racial bias, we'll say. So you could either vary from pro-white bias to pro-black bias, or no racial bias at all. So this group looked at all these studies of healthcare practitioners taking this test. Within their inclusion criteria, they found 35 articles. In these articles, they found that it was taken by med students, residents, fellows, attendings, physical therapists, chiropractors, nurses, a lot of people in the healthcare profession. What they found that was that 74% of these studies showed anti-Black bias in these results. Looking at different ethnicities, there wasn't a lot of data, but 3 out of 3 showed an anti-Hispanic bias. So 100% of the studies that looked at Hispanic bias had an anti-Hispanic bias. And as you can see, the studies that they found looking at anti-Black bias and anti-Hispanic bias was from 2019 to 2016. One good thing was there seemed to be an anti-female bias when they looked at that. So overall, it's decreasing as time goes on, which is a good thing with this. Well, we want to look at more data. So in this same study, they looked at a few articles to see in what areas did our bias affect interventions and affect the way we communicate. So in all these studies, you could see that in some studies, the bias was present and absent. In 38% of those studies, it showed that our interventions we choose for people are affected by our implicit bias of gender or race. What's most important is we pride ourselves on communication. I think that's what a lot of people study once they're done with med school about how we can build a rapport. 83% of the study showed that implicit bias affected the way we communicated and perceived certain genders and certain ethnicities on the way we communicate, which is unfortunate. And again, this was all from 2018 systematic review, but right now I'm sure there's a lot of you who are like, I don't quite believe you yet. I don't think there's sufficient data. Maybe you're like, what is this guy doing? He probably just wasted all our time, but we get free pizza, right? There's a certain thought of that. If you're at the lunch meeting, of course. But maybe Dr. Fauci can be more of a credible source. So he actually brought this up most recently. He talked about this about 3 days ago during a press conference for COVID-19. Dr. Birx was actually talking about the data and the different models, and she wanted to bring up the fact that the Black community seem to have higher rates of infection and higher rates of death. But she wanted to make sure that people understood it's not because they're Black, it's because there is a big health disparity in that group. And then unscripted, Dr. Fauci actually went up and had these words.
I just want to make a brief comment to get back to the discussion about the health disparities in the African-American community, because it really is very important. And the reason I want to bring it up, because I couldn't help sitting there reflecting about sometimes when you're in the middle of a crisis like we are now with the coronavirus, it really does have ultimately shine a very bright light on some of the real weaknesses and foibles in our society. And as some of you know, the greater proportion of my professional career has been defined by HIV/AIDS. And if you go back then, during that period of time when there was extraordinary stigma, particularly against the gay community, and it was only when the world realized how the gay community responded to this outbreak with incredible courage and dignity and strength and activism, that I think that really changed some of the stigma against the gay community, very much so. I see a similarity here because health disparities have always existed for the African-American community. But here again, with the crisis, how it's shining a bright light on how unacceptable that is. Because yet again, when you have a situation like the coronavirus, they are suffering disproportionately. As Dr. Birx said correctly, it's not that they're getting infected more often, it's that when they do get infected, their underlying medical conditions, the diabetes, the hypertension, the obesity, the asthma, those are the kind of things that wind them up in the ICU and ultimately give them a higher death rate. So when all this is over, and as we said, it will end, we will get over coronavirus, but there will still be health disparities, which we really do need to address in the African-American community. Thanks.
So as you can see, yes, there can be genetic factors that influence one group versus the other into having such cardiovascular and metabolic diseases. However, as you can see by the evidence I provided, that what we're born and grow up in, as far as environments and what we're dealt with, can affect health outcomes. So right now, that's a lot to handle. This is a heavy topic, and a lot of people are wondering, what can we do? Well, the main thing to remember is we're currently living in a box right now where we were taught to treat a certain way, but healthcare is changing, and because we're aware of all this, we have to think outside the box. So when we think outside the box, we can develop solutions to decrease health disparities in our local communities beyond the clinic walls. And that's why I'm doing this whole talk. And when we talk about developing these programs, it seems very daunting, but I think the solutions we think of can be very effective if we go about it the right way. And I think a good model to look at is what Dr. Jonathan Mann presented. He's an American physician and epidemiologist that sadly passed away in 1998, but he was most known for studying AIDS during that time. And there was a really good article reflecting on Dr. Mann's life and work. And the reason he was so well liked was this quote from that article. And it said, Jonathan argued that discrimination and other violations of human rights were primary pathological forces working against the improvement of public health. At that time, they were actually figuring out how to at least manage AIDS. But the biggest restriction was discrimination against certain groups or their access to these interventions. So if we look at his model, called the Human Rights Impact Assessment, we can use his model to make sure we're inclusive and we target the groups that we want to help improve our communities around. So now I'm going to go into this model to help us determine how we can develop certain programs around our community to help them. So step one of this model is to clarify the public health purpose. So we want to make sure that we have a purpose for a specific group. We're going to look at who we can help and determine what they need the most help with. Next, we're going to look at evaluating health policy effectiveness. We're going to look at experts, we're going to look at current evidence and look at past interventions to see what was the most effective intervention. And then we're going to see how we can put that into a program for the community. Next, we're going to determine if the policy is well targeted. Again, we talked about how public health can be a little too broad. So with us at this step, we want to make sure that we target a population without excluding certain groups while including the group that we really need the most. And this part is hard because we're going to have to exclude certain groups, but really we want to target the group that is really going to benefit from the interventions we consider. So we want to really take this step in consideration and a lot of focus, but we just have to acknowledge that we are going to be exclusive to a certain point. Then we're going to look at human rights burden. So because one group is getting a service, is that going to take away from another group's rights? Is that going to take from another group's resources? So we have to be mindful of that. Next is step 5. Again, we're going to determine if it's the least restrictive. We're going to observe all the possible scenarios out there and determine if our new program that we're going to develop is the right thing. And this could save us from a headache. Let's say we get to step 5 and we find a program that's already going on that meets everything. We actually put that program through an assessment in HRIA and we find it successful. Well, we don't need to develop the program. We just need to help. We need to maybe reach out for to consult them. That might be a solution. If we get past that and determine that our program is still the best, we're going to move to step 6, which is going to look at significant risk standards. So obviously there's always going to be risk. So we have to determine and sit there and think about the hypotheticals. So what if this crazy scenario came about? Look at it case by case. Is there a risk to excluding this person, or is there a risk of this person being in this program? And we have to reassess this and go back to step 1 and do it all over. But this one, we're going to have to assume significant risk versus acceptable risk. Acceptable risk is something we're going to have to agree with. We just have to make sure that there's not significant risk to a large majority of the population we're targeting. The last step is to guarantee fair procedure to individuals affected by all this. So really what that's saying is we're going to assess things. So we're going to talk to the community, talk to the group that we initially targeted. We're going to ask them if they felt like their intervention was successful and whether they liked the program. We're going to talk to the experts who helped us and see on an objective level, does the data show that this was effective in what we wanted to treat? So you're looking at this 7-step program and you're thinking that is a lot, that is confusing. It's too specific. I didn't learn any of that in med school. I didn't learn any of that in nursing school, athletic training school, whatever discipline you're in. But if you actually think about it, you actually were very well trained in this as early as your first year in medical school. So remember, a lot of step one is talking to the community, talking about experts, asking what they did before, what worked well for them, worked if they're going to be able to comply with it. A lot of it's a subjective history. Steps 5 and 6 are really determining the intervention. So that's our part where we determine based on the subjective history, we think this is going to work best. We're going to look at the risk and benefits of such intervention. And then step 7 is simply our test retest. So this is our follow-up visit. Did it work? Did what we prescribed work? Were we correct? Is there adjustments needed to make to their intervention? So if you look at this subjective intervention, test retest, aka follow-up, you've all learned this. It's just a different mindset of thinking. And that's what I mean by thinking outside the box. It's taking our current skills, our current models of care, and seeing how we can produce this for on a community level. But you'll understand that the most important part of this, the majority of this, is all about this, taking excellent subjective. It's what we learned in medical school. It's what we learned in our healthcare training. That subjective trumps most exams that we have. Really can guide us towards interventions. So the 7 steps was pretty confusing. So I'm going to give you guys an example in physical therapy. So let's develop a program in the context of physical therapy. For step 1, we're going to identify a purpose. And for me, I'd like to develop a fall prevention program for the community. And I think this is warranted because let's say I live in a community with older adults that have high hospitalization due to fractures and even death. So step 2, I'm going to develop its effectiveness. Well, I already know there's a large body of research and a lot of experts and even anecdotal evidence from patients that tell me exercise and cardiovascular fitness and strength and balance definitely help with self-reported outcomes of how confident they feel, and also functional outcome measures of balance have been shown to improve with these modes of exercise. Next, I'm going to determine if the policy is well targeted. So let's say I live in a rural community. I'm going to make sure these classes are accessible to all. I'm going to make sure that people with low income can access it. So I'm going to develop grant funding so it can all be free. I'm going to look at gyms, parks, hospitals, and healthcare facilities to make sure that people without cars can have access that are walking distance to them, or they can easily find a ride to short distances around them. That's the group I'm going to target. I'm going to look at the burden. Again, does this infringe on other people's rights and resources? So if I'm using other facilities, I'm going to use non-peak hours. So because I don't want to get in the way of other people getting better, improving their health, I'm going to choose these non-peak hours for them to have these services. Step 5, is this the least restrictive? I'm going to look around the community. Is there anything like this? Are clinics already doing this? Many clinics are, so I'm going to look at those programs. But what if I see something that's specialized in my care? I'm going to go ahead and determine that I'm going to move forward with my program, and I won't be participating in the clinic's programs. The other thing I'm going to look at is transportation. So is my program, based on where I hold it, again, in a rural community, maybe some people don't have cars, maybe public transportation isn't that great. Maybe the clinics is a better route because there's more maybe chain clinics that can have access. But still, I'm going to proceed forward with my case. And I'm going to look at step 6 now with significant risk. Again, I'm going to do those hypothetical cases. Well, what if someone is on, requires a walker or cane? Are we going to exclude them? Because technically, if they're at fall risk using DME, then they're probably going to be the most beneficial for this program. So can they participate? Well, again, I'm going to think about my program. I'm going to think about how many people per participants there are, supervision, modifications we can exercises. So I think we can do that. Is it advertised in several ways to reach those who do not have access to technology? So what if people don't go on the internet? They can't see these ads. I'll make sure that I don't include, or I make sure I include these people by going and handing out flyers, posting them up. So the significant risk of someone not showing up is eliminated. And then are there options for those taking public transportation reach class? And I already mentioned that maybe I can think of services in the community where people can provide rides for these patients at certain hours, at certain pickup spots near their homes. And lastly, step 7 is to guarantee fair procedure to individuals affected. So I'm going to interview the groups that I helped with all this. I'm going to interview the experts, and I'm going to look at my objective data. I'm going to look at patient-reported outcomes, see how they like it. I'm going to ask them for their feedback about the quality of the programs. Do they felt like there were modifications well? Do they felt like they were respected? They felt like they were encouraged to come back? Were there any barriers to that? For objective measures to see effectiveness, I might take balance scales, functional outcome measures such as the Tinetti or Berg balance test. And then if I've went through this whole list and determined those are a good procedure, I'm going to start and implement this program. And so some examples of this are seen in many areas I've lived. So looking at accessibility, example of that is, are athletic trainers accessible? In California, it's the Wild West there, and there's no licensure for athletic trainers. I believe it's the only state with no licensure. So that means that you have random people that aren't medically trained taking care of athletes and triaging. So what Ross Nakaji did was, he's a private practice owner, is he got funding from the 49ers, all these local foundations and hospital systems, and he actually does all the hiring of athletic trainers and makes sure that he sends them out to these local high schools and making sure they have good care. So in communities without access to good health care, he's decreasing the cost of a lot of unneeded procedures by having athletic trainers out there to help triage these athletes out there. Another example of accessibility is, what if people don't have gyms around them? What if in the community there just wasn't access to gyms? Well, in Wisconsin, there was a town called West Salem, and what they had was their weight room open at the local high school. Again, during non-peak hours, the community was allowed to go in there and use the gym, and it was very popular. I'd see it whenever I was there, like just twice. The track would be filled, the weight room would be filled. It was a really good program. So this increases accessibility. Well, remember when we talked about built environments? So I actually volunteered for a group in California called Volunteer California. Do you guys ever hike and notice that these trails are a nice beaten path? You're probably thinking, well, maybe people just kept on walking until it actually flattened. Well, actually, people actually make those paths. So this is what I did. On a few weekends, we'd go out to a lot of different parks and we'd trailblaze, literally trailblaze, just like the olden days. And it was a big procedure, even about like 80 people for 2 days. We could cover maybe 2 to 4 miles of trail. But this encouraged people to get out and exercise because it provided an actual structured area where they could exercise, but also safety. You can imagine that maybe people with poor balance the trails might have prevented ankle sprains. So built environments can help promote exercise and can prevent injuries. Next, looking at built environments is my hometown of San Jose. If you see the bottom left, those are the bike lanes, big and green. And honestly, I was pretty pissed when these first came out because there were 30,000 of us at my high school or university. So there wasn't much parking spot for all of us. And it was definitely a commuter school. So when these came out, you can imagine how much parking spot it took up. And for the first year, it'd be empty. But within a year, that's how it looked. I mean, people were using these bike lanes. More students were biking to school. It promoted a lot of exercise. And also, you could realize how far the cars are from the sidewalk. So more people were encouraged to walk overall. So again, the built environment can encourage exercise overall and safety, the perception of safety to encourage more people for exercise. Next is the top left corner. You'll see that a local track, they built a exercise for adults, a little exercise jungle gym. So you could do a lot of calisthenics on this machine, and it was very well occupied throughout all months of the year because, of course, California has great weather. In that same track on the right, you'll see that its pictures lit up, or the track was lit up. Not a lot of tracks have lights. Not a lot of people have places to run at night. You can see how that might be a safety issue too. There was high crime rate where I grew up. So this provided a place, at least safer place for people to exercise. And in that picture, you could see that it was a pretty good turnout. And this was pretty much every night. A lot of people would still come out there just to exercise. So again, by having these environments out there promoted exercise, you can encourage this. And right now you don't have to build it yourself, but you could help write grants. You can contact community centers. You can contact high schools. You can ask if they were willing to implement any of the systems, and you can certainly assist in that. So that was a lot to cover, but the main takeaways I want you to think about is we all signed up to help society based on all the mission statements. And some of us may have to treat beyond the clinic walls. I definitely think the clinic care is important. I'm not arguing that we need to get out of the clinic. I'm just saying we have to consider it, and we may be able to do both. I think that's what's going to implement and influence the community health programs the most. Implicit bias exists today and affects patient outcome. So even when we're inside the clinic, the way we perceive certain people can affect their outcomes. And we have to be very aware of that. So before you even enter the patient door, check your biases, look at their social determinants of health, be considerate, make sure you're giving the best care based on what they need rather than your implicit biases. And it's hard. Lastly, you have the credibility and knowledge to truly help society. Support, consult, or build these community programs. A lot of us have nice letters on our name, and maybe we work around each other daily and we just think it's just letters. But to the public, people hold a lot of power in the letters MD. And I think when you go out to the community showing your letters of MD and DO, I think it's important that you back programs for people to be supportive and for them to say, that's a legit program, we're gonna actually take part in that. So really pride yourself on your credibility and knowledge of being a physician or soon to be a physician. And I hope these takeaways empower you, make you feel ready. Maybe you don't have the solutions, but you have the awareness and you have a general outline of what it takes to have these programs run and to help your community. And these are my references. And so again, I'd like to thank you all for sticking around for a little over 40 minutes and listening to me banter about this, but this is a topic I'm very passionate about. And as soon as I get a permanent home, I plan to think about all these things and implement programs for my community. So again, thank you and have a great one.